We are delighted to welcome Dr. Ali Khan to this breakfast program. Dr. Khan will be discussing his book, The Next Pandemic. As the former director of the Office of Public Health Preparedness and Response at the Centers for Disease Control and Prevention, Dr. Khan has been on the front lines in the fight to contain the world's deadliest diseases.
I'm really delighted to have this opportunity to share a whole bunch of stories with the broader audience of what it means to be a disease detective and hunting down these diseases. And you hear about patient zero, and if you read the papers, all the popular press, the movies, et cetera. But what is it from the perspective of somebody who's been doing it every day with lots of other amazing public health practitioners? And also, it's nice to give a talk when, if you read the paper this morning, you're either reading about Zika or Ebola or yellow fever going on in Angola. So it's topical, so it makes it easy to start a discussion off about emerging infections. So let's just start there. And the idea of why is this always in the paper, and why are we always hearing about these types of diseases? Now, our classical diseases, think about smallpox, think about measles, those all started pretty much around the agricultural revolution when people sort of came together because you needed to have enough people to spread disease from person to person. And so that's when my story of infectious diseases starts. Everybody has their own story of when the world starts. But for me, that's when the world starts, when some rodents that were carrying some version of smallpox moved into somebody's home, and that virus made this jump and caused smallpox in people. Same thing for measles, classic diseases. Well, let me fast forward you to the Industrial Revolution. Germ theory, we realized that infectious diseases weren't due to miasmas, but they're actually due to infectious agents that spread from person to person. And a lot of enthusiasm that occurred around the beginning of the 20th century with the sanitation revolution, vaccines, antibiotics, and people thought, okay, we're done with this whole infectious disease problem. All we have to do is pop a shot in somebody's arm, give them a couple of pills, and they'll be all better. Well, if that was true, we wouldn't be having this conversation today, right now, right? And what's happening is that even though we've taken care of a lot of these classical scourges, we have these continued emerging infectious diseases. And there's a lot of factors that drive this emergence of those diseases. So some of the key factors are just around microbes. Collectively, I'm somebody who thinks that they're smart collectively, and they evolve. They have multiple generations with a single day. Humans, if we're lucky, a generation in 35 years or something before we can swap out our genetic materials. Microbes, no problem at all. They swap genetic material all the time. They get smarter all the time. It's why you read about these drug-resistant microbes, because that's what they do. They sort of move around, they find a good set of genes, and they go, oh, this will protect me from these set of antibiotics, and boom, you get your superbugs. So the microbes evolve. Humans change their behaviors. So 100 years ago, I could tell you nobody had a kidney transplant, okay? And so we change, and our risks to infections change. The other thing that happens is we change our environment, and this is a big driver in why we have emerging infectious diseases. It should not be surprising that when I talk about Zika, when I talk about Ebola, somehow very quickly the animal connection comes into play. With Zika, obviously, it's with mosquitoes. With Ebola, it's bats, which are the original cause for where this virus sort of lives. It infects somebody, and that's how you then spread out the chain of transmission in humans. 75% of the diseases that you hear about, the new diseases, these emerging diseases, are zoonotic. What that means is they have an animal connection. And so if you move people out into the environment, into the jungle, they get infected. And that disease has the potential then to cause person-to-person transmission, as we see with Ebola, or let's say with MERS, which we believe is from bats and camels. And so if you're having somehow contact with camels, that's how you get the disease. And so it's not a surprise when we think about these emerging infections. They tend to come from Africa or South America or parts of Southeast Asia, where you have a lot of connection with animals. Bird flu is another good example, where you have people in China and other parts of Southeast Asia who live very close to their pigs, live very close to their birds or fowl, chickens, and there's a great opportunity for these viruses to swap their genes and eventually infect humans and then become global pandemics. So those are the some set of environmental conditions why that lead to these infections and why we keep hearing about them. I want to do a special call out to climate change as one of those environmental factors that lead to emerging infections. First, I want to say is often climate change is framed as either an economic issue or has somehow energy issues. And I think over the last year or two, we've been doing a better time reframing this actually as a public health issue of what's happening with climate currently. I got into climate change business 20 years ago almost, and it had to do with Rift Valley fever. So this is a mosquito-borne disease in Africa. So if you're in Africa, you don't have a 401k, okay? You have your cows, you have your goats, that's your 401k. So if a mosquito-borne virus comes around and your animals die and are aborting, that is bad news. And so that's Rift Valley fever. It's a biblical disease. And what we've recognized over the last couple of decades of studying this, besides the fact that it's moving out of sub-Saharan Africa into northern Africa and into the Middle East, is that it actually depends on climate when this mosquito emerges. And you sort of have to have these great heavy dry periods followed by wet periods to cause this to happen. And to protect your animals, and this virus, Rift Valley fever, also causes bad disease in humans. It causes abortions in humans, it causes hemorrhagic fever, and it causes brain inflammation and blindness in humans. But the farmers, they don't have the money to vaccinate the animal every year. So if you had some sort of tool every 5 to 10 to 15 years to say, you know what, this is the bad year, get vaccinated this year, that would really benefit them. So people have spent a lot of time trying to understand what happens to weather and climate so they can help protect these farmers and protect their animals, and then obviously the community. So that's how I got into climate change issues, was understanding what the dynamics were. And what became very clear right now is when we talk about climate change, everybody's like, well, what's going to happen in 2100? Well, no, it's really what's happening today. So the biggest disease in the United States that's caused by arthropods, which are ticks and mosquitoes, is actually Lyme disease. And which everybody in this audience knows very well if you live up here in the Northeast. So if you look at where Lyme disease vectors are spreading, they're actually, over the last 20 to 30 years, have continued to spread across the United States, where they're almost in about half of the US counties. So we're seeing that already today. There's a tropical fungus up in Vancouver causing infections of humans and animals. It doesn't belong in Vancouver. It belongs in the tropics. Again, contemporary examples right now that are only going to get worse when we think about heat waves, when we think about heart and lung disease from all the air pollution, and then obviously all the infectious disease. Anything that has to do with mosquitoes and ticks and where things are, climate plays a big role in those. And then there's foodborne illnesses, there's waterborne illnesses that are an issue with this as we get flooding, obviously severe storms, and mental health illnesses. So I want to make a quick shout out to climate change as one of the factors to keep in mind as you think about emerging infections. Now, the biggest factor of all of these, and all of these are important, what's happening to the microbes, what's happening to us, what's happening in the environment, is actually more political social factors. And these diseases will continue to emerge, as I hope I've convinced you over the last 5 to 10 minutes. But I think we play a role in keeping them from becoming epidemics and pandemics. A good example, for example, would be the recent outbreak of Ebola in West Africa. So it wasn't new, right? We've known about Ebola since 1976. We've known about the science of Ebola since 1976, and I had the opportunity to help support that science in the mid-1990s when I did an Ebola outbreak in Zaire. So what happens? You get infected with Ebola, usually probably with a bat, and if you're out way in the bush, you die. 85 to 95% of people die. Unfortunately, maybe a family member or two will die with you, but you're out in the middle of the bush, you're done. Let's say you change that dynamic and you decide to go seek health care in a hospital. Unfortunately, in a hospital that doesn't have infection control. So when you're infected with Ebola, you essentially become a virus factory. And you get infected, and if your immune system doesn't kick in, you're just increasing the amount of virus you're producing every minute until you die. So here you are, sick, dying in a hospital, and somebody doesn't wash their hands as they go from patient to patient. What's going to happen? you're spreading Ebola from patient to patient. And so hospitals have always served, and we've known this for many years, as a reservoir for how these diseases get amplified and spread within their community. Somebody's sick at home and you're the family member taking care of them, you're at risk. Science, we know that. They die, unfortunately, and then you decide to wash the body, kiss the body, hug the body, invite all the loved ones. One of the practices we saw during this Ebola outbreak is they would wash the body, and then they would use that water to allow little kids and other people to wash their hands to take on the attributes of this sainted person who had just died. This is not a good idea, okay? Let's admit that. So, but that's the science. We know the science, right? But the science isn't the issue. So when this outbreak occurred, and I think this was some 24th, 25th, something like that, outbreak of Ebola we've seen since 1976, many people had thought, oh, this is just going to be like what we've been seeing happening in East Africa. Uganda sees outbreaks all the time. They shut them down within a couple of days. They have a system in place to identify the case. You know, a team's rush in. They don't even need international teams anymore. The locals know exactly what to do. They rush in, they test everybody, they follow everybody who's potentially sick, and they extinguish these outbreaks very quickly. And so this outbreak occurred in West Africa, where it's never occurred before, so nobody had seen the disease before, and it very quickly spread to urban areas, large metropolitan, dense urban areas with slums. And the thinking was, oh, more of the same, you know, rush in, take care of everything, and this Ebola outbreak will go away. What happened? That's not what happened, right? So 11,000 deaths, each and every one was a needless death, I would say, and an inadequate response, global response. Inadequate local response, obviously, but an inadequate global response. And so politics and our public health systems play the biggest role in whether or not this goes from a handful of cases or a small outbreak to whether or not you now, what we had was essentially a epidemic across West Africa with seeding of cases across the world, including, obviously, we know what happened here in the United States. And one of the reasons we had that case in the United States is another factor, a social political factor that plays into infectious diseases that we didn't have in the 1800s. So how many people, I won't ask because the answer will be yes, have read Around the World in 80 Days or have heard of Around the World in 80 Days? How quaint! 80 days to get around the world, okay? So for 22 years, I wore a public health uniform. And on my public health uniform was an anchor. And I would get asked about the anchor on the public health uniform. The public health uniform looks very much like a Navy uniform. And the reason it looks like a Navy uniform is we started about 200 years ago providing care to merchant Marines. And one of the chores of the public health service, which we still have right now, was essentially to fly quarantine flags when a ship came into port and there was somebody with yellow fever or smallpox on it. Well, if it's going to take you 80 days to go from point A to point B, by the time you showed up in the port of New York City, we knew if you had smallpox. We knew if you had yellow fever, because the incubation period, the time it takes to get infected, to manifest your symptoms, was always shorter than the time it was going to take to go from point A to point B. Well, we've turned that upside down now. So you could now go to your mother's funeral in Liberia, right? So you fly to Liberia, go to your mother's funeral, engage in the usual acts that you would around a funeral. You know, you're distraught, your mother's died, you're kissing her, you're hugging her, and then the next day you get on a plane up through Amsterdam to New York City. Okay, so we've got what? 18, 24 hours, maybe 48 hours, incubation period of 5 to 7 days. Well, it's 3 days after you show back up in New York before all of a sudden you go, you know what? I've got a headache, and I've got a fever, and I'm not feeling quite well right now. You show up at a hospital. If it's a good hospital, their number one diagnosis will be malaria, 1, 2, and 3. If it's not malaria and they miss this, then it's very easy to see how, you know, you get hospitalized for something and you can spread disease within the community. We saw this happen in Texas. Exact same scenario. Somebody showed up, came home, infected 2 local nurses. So travel has played a big role in how these diseases emerge currently. I think I've sort of given you a sense of why you'll always hear about this, but what we can try to do to make things better around the social political aspects of protecting people. I did want to spend a couple of minutes to talk about you at the Carnegie Council that says ethics matters. And this, an observation, which I guess I've recognized it my whole life. So if you think about HIV and who gets infected with HIV, it's often marginalized populations. But as I started to write the book, it sort of dawned on me how almost every chapter you could pull out the marginalized population that was increased risk for emerging infections. So think about hantaviruses. This is a disease that's due to rodents, often occurs in the southwestern United States, and the most likely people to get infected and where the original outbreak occurred was amongst Native Americans. And some of you will remember that when this hantavirus outbreak occurred in the early 1990s, there was this group of young Navajo kids who had come to DC for a Capitol tour, and they were denied a tour of the Capitol because, oh, you happen to come from the Southwest. You could potentially be infected with hantavirus. There was nothing in anything we knew that said that these kids were at risk, and they weren't. They didn't pose any risk to us. But often these diseases affect marginalized populations and helps increase some of the prejudice against those marginalized populations. I've already talked about HIV. I've talked about a little bit about Ebola and these sort of poor marginalized populations in West Africa. And today's day and age, we're talking about Zika, right? In the marginalized population, there are poor pregnant women in Brazil. So Brazil has about 1.1 million cases, I think is what they're calculating now, of Zika virus, and over 1,500 women who have been infected and their babies have gotten congenital Zika syndrome. And this is a severe illness of babies where they get small brains, other developmental disabilities, including hearing loss and vision problems. And what we've learned now is Zika is essentially a laser-guided missile for neurons. It looks for your neuron cells and it kills your neuron cells. And it's not just true in babies. So when Zika was first described, what we were told was, yeah, about 20% of people will get sick. And if they get sick, they'll get a fever, they'll get a little headache, they'll get some itching, some red eyes, and they'll get better. Then very quickly it became clear that this was a problem for pregnant women. But now we know even for adults, because of this sort of laser-like focus on neuronal cells, we have this disease called Guillain-Barré syndrome. So this is a neurologic illness that causes weakness. And we also know that even in a healthy person, Zika virus can cause brain inflammation and inflammation of the coverings around your brain. So even in what we should think otherwise normal, healthy adults who are not pregnant, this virus is a problem. This virus shouldn't be a problem, okay? The virus is spread by something called Aedes aegypti. It's a certain type of mosquito. This mosquito is not new to us. This is the exact same mosquito that spreads yellow fever that causes about 30,000 deaths a year. This is the exact same mosquito that spreads dengue. And if we were having this conversation about 5 years ago, we would be talking about this large dengue outbreak that's occurring in South America. This is the exact, and dengue causes, I think, about 30,000 deaths a year, something around that. This is the same exact mosquito that causes chikungunya virus. That was the big thing in the news 2-3 years ago. That one doesn't seem to cause any deaths. But because of the failure since the 70s to keep up with these efforts to decrease mosquitoes and kill mosquitoes, and not paying attention to the people dying from yellow fever, the people dying from dengue, now all of a sudden we're all up in arms that, oh, we have a disease due to Aedes aegypti that seems to be infecting pregnant women. So there's this lack of action over the last 40, 50 years against a known threat that has put us in this current position. Margaret Chen, who's the head of WHO, brilliant woman, did some amazing work in her time in Hong Kong, has admitted a major policy failure over the last 40 years in addressing this mosquito. Also, she broadened it to talk about major policy failure as we think about protecting women and contraceptive rights for women, because this is a big issue in Brazil and other places where they don't have the same sort of contraceptive rights as you take for granted here in the United States and other parts of the Western world. So why did it take all this time, people dying of dengue, people dying of yellow fever, which is a vaccine, to all of a sudden say, oh, you know what, we need to pay attention because now we may get some cases in Europe and in North America of women who may have this disease. What I'll leave you with is a number, because I'm all about observable measures. 6.7. So in the last 3 years, the Robert Wood Johnson Foundation has been doing some great work looking at how prepared the United States is for public health emergencies. And every year gets a little bit better. I think we started at 6.3, but 6.7 out of 10. That's just not good enough for us here if we really want to make sure Americans are protected against public health threats. And as far as I'm concerned, the responsibility of government is to protect us against threats, and that includes public health and health threats. And how can we make sure, I'm old enough now to realize you can't completely strip politics out of policy decisions, and it's not always about the science, but maybe sometimes we need to be stripping a little bit more politics and thinking about what are the health needs of our population. Thank you.
Well, that was fascinating. You seem so calm, though. What keeps you up at night, if anything?
Yeah, I think I'm calm because I decided 20 years ago that fear is not a public health strategy. And I know it makes for great press, the sky's falling, but really it's about education and good science. Now, what keeps me up at night is what the next pandemic's likely going to be. And Zika is a pandemic, needless to say, but it's not causing hundreds of thousands of deaths. What's likely to cause hundreds of thousands of deaths in the future is flu. We already know that from 1918. So if we did a repeat of 1918, so we get flu every year, and I'm going to tell you right now, my public health message of the day is get vaccinated. We get flu every year, and it changes a little bit, which is why we need a new vaccine every year. But unpredictably, flu just takes off its overcoat, and all of a sudden, you have no protection against it at all. And if we repeat the same thing we saw in 1918 today, 7.5 million Americans would die. Okay, 2.5%. Think about the number of body bags. Think about how this would completely disrupt our society if within a couple of weeks to months we killed 7.5 million Americans. So flu keeps me up at night. MERS and diseases like MERS keep me up at night. I do know, I've seen these health systems. Our health systems are getting better. Our ability to respond to diseases are getting better. Part of my job at Nebraska with the National Ebola Training Center is helps hospitals get better. But we know the risk of healthcare-acquired infections here in the United States. And so I worry about MERS as another example. A third example, and I'll stop at the third example, is the next HIV/AIDS. So, HIV/AIDS, nowadays, you think of it in terms of sexual behaviors or IV drug abuse that get you HIV/AIDS. But let's remember, HIV/AIDS was another one of those zoonotic diseases. It came from non-human primates, probably multiple times, and one time it was the right version that made its way into humans, and then it spread from human to human. So I worry about another stealth virus like that spread through sexual transmission or some other mode, has a long incubation period before you get really sick, and by the time you discover it, it's already spread widely. So those are some of the things that keep me up at night about what the next pandemic could be that would have really significant morbidity and mortality.
That was too fascinating, and especially in the morning. But we have to be concerned about what can be done. And here you're the most experienced person. How can the U.S. do more and CDC do more to prevent these outbreaks?
How we can do more starts for me at multiple levels. And you always tell people they're more powerful than they think they really are. So let's start with something very simple, healthcare-acquired infections and drug-resistant microbes. So a paper came out last week that suggested 1/3 of all the antibiotics we're using are unnecessary. So as a patient, when you go in and talk to your doctor, you are powerful to say, do I really need this antibiotic for my cold, doc, or is it something we can work out for a couple of days, and then if it doesn't get better, I should take an antibiotic? You have that power. You have that power when you walk into a healthcare facility and a doctor or nurse or respiratory technician walks in the room to say, did you remember to wash your hands? Okay? You are powerful. Do not forget that. You have the power within your community when you think about personal preparedness issues. So if let's say a pandemic runs through your community or a natural disaster runs through your community, are you prepared personally for that, not just in terms of having a kit in your home and being ready, but are your vaccines all up to date? How many people in today's cell phone ages actually know a physical phone number? Am I part of a response team within the community? Have I taken a CPR course so that if something bad happens, I don't need to call 911 for the little teeny things? I could take care of something small myself or help somebody else. Am I a blood donor? So there's all sorts of things we can personally do. And then it's things that we should expect from our government, and that's where we're powerful. So if tomorrow morning in New York City we decided, you know what, let's lay off half the police force, my guess is you will tar and feather that mayor because you think public safety is so important. But the same thing is happening invisibly to your public health safety workforce here in the United States, where it's not fully funded. And nobody is tarring and feathering anybody when you get a score of 6.7 and how prepared your community is or how prepared your state is. So to demand the same thing from your local representatives and demand the same things from your national representatives, that we want a little less politics in what is happening in our health. Why are there still 28.6 million uninsured Americans in the United States right now, given the fact that we passed the Affordable Care Act? You know, 19 states that have not passed Medicaid expansion. So I think you are powerful and you need to expect more and ask for more at every level, including your own level.
I would just like to thank you for really an exciting journey you took us on this morning. It was a wonderful talk, and the book is available for you to purchase. Thank you.
For more on this program and other Carnegie Ethics Studio productions, visit carnegiecouncil.org. There you can find video highlights, transcripts, audio recordings, and other multimedia resources on global ethics. This program is made possible by the Carnegie Ethics Studio and viewers like you.